Hello and welcome to another Piper Pod. Today we're going to continue with our wound care package and we're going to move on to modes and aberrants of wound healing. Now this will follow on from the physiology of wound healing lesson that we did before. So we'll kick straight into it and we'll just have a look at, first of all, the modes of healing. Now modes of healing are referring to states in which we put a wound in order to give it the best advantage in healing properly. Now this is based on a lot of factors that we'll cover in future lessons, but just going over them first, they're broken up into three main modes of healing. We have our primary intention. Now this is closure of a surgical or traumatic wound where your edges of the wounds are held in close opposition to one another. This is either by sutures, staples, tapes, or even adhesive glue sometimes. Now, as a result, there's usually minimal tissue loss and minimum scarring as a result of primary intention. So when you can, it's always the way to go, hence why it's called primary intention. Now, secondary intention is when you have that wound, but it's left open to heal spontaneously and occurs by obvious process of granulation, contraction, epithelialization. So the wound's left open and you can witness these things occurring. Now as a result, obviously because there's a large opening and they're not close together, it's going to has the need for fibrous-based tissue to form, which leaves a scar. Now the third one, which is tertiary healing, which is also known as your delayed primary intention, is where a wound is kept open for intensive cleaning, or when an infection is identified or it's assessed that there's a high probability, or even when there's a foreign body found within the wound. Therefore primary closure can't take place until the infection is gone. So usually it's left open for about 3 to 7 days and then you go on to trying to get primary intention. Now the reason these are important to know is because when we start moving on to wound assessments and looking at certain dressings and things like that, we'll be referring back to these modes of healing and what our goal is when we're dealing with wounds. So first of all, we need just a basic understanding of what they are, and then we can move on to how to assess a wound properly from there. And when you have a large wound or a complicated wound, different techniques are put into place in order to best speed up the healing process. Now one of those techniques is known as skin grafting. So a skin graft is simply where a segment of the epidermis and the dermis has been removed from its blood supply and transplanted to another. Now there's a whole bunch of different types of skin grafts that we'll quickly go through now. The most common one is an autograft. Now, an autograft is a surgical relocation of a segment of skin. Now, as mentioned, that's usually the epidermis and varying thickness of the dermis depending on where they get it from. Now, the term autograft means that it actually comes from the patient itself. So as a result, a second wound results, and that's what's known as the donor site. Now, this is allowed to heal by secondary intention and epithelialization. Now, autografts are described as split thickness skin grafts, and they can vary in thickness. Now the thick ones will often have the hair follicles within them, whereas the thin or intermittent ones will not. Now once the skin graft is taken, it's usually laid out on a sheet and then put through a machine where it turns it into a mesh. Now the lattice or the mesh material will facilitate the ability to cover a larger area of defected skin. Now because autograft is the most common one, we'll just spend a little bit of time talking about how an autograft skin graft is placed onto the skin and the healing processes it goes through. Now as soon as the skin graft is put on the wound, it goes through a process known as plasmatic imbibition. Now what that means is it begins to absorb the plasma-like fluid. Within the first 48 hours, a fibre network begins to form between the graft and the recipient's bed, which helps to anchor the actual new skin down. From there, we start getting the formation of new blood vessels, and this occurs within the first 48 hours as well. So these vascular buds start to grow within the fibrous network and help anchor the skin graft as well. From there, about the 4 to 7 day time period, we start looking at true circulation. Now this is where new capillary activity is established in the graft, and your lymphatic system is established at the same time. Final stage of the skin graft healing is the maturation of the graft. Now this is where your collagen deposits occurs between the recipient beds and the graft itself over time. Now the healing of skin grafts can take a fair while, and they do need a lot of care. You also need a very talented surgeon and nursing team in order to take care of them, which generally means that they're very difficult and a lot of mistakes can be made. So because of that, science has come along and tried to come up with different techniques. One of those techniques is a process known as cultured epithelial autograft. Now this one here is a lot more sciencey, and some would say a little bit less barbaric, because it actually involves the collection of keratinocytes from a skin biopsy. Now, the biopsy only has to be about 2 centimeters in size, as opposed to a large skin graft that gives you a secondary wound. From there, the keratinocytes can be harvested at the same time as surgery and used within 15 to 20 minutes, or in the case of a burn victim, they're collected within 24 hours of the burn injury and prepared in a lab for future use. Now, in the lab, the keratinocytes obtained for the biopsy are placed in a kit known as a ReCell kit, and that separates and incorporates into different cultures or mediums of growth. Now, once ready, they can be sprayed onto the wound directly. Okay, and they can be sprayed into the actual mesh from other skin grafts as well. Now, the keratinocytes can also be prepared in a laboratory and harvested from the same biopsy and then separated into different mediums of epidermal growth factors. Now, they can grow up to 50 to 70 times the size of the original biopsy within 5 to 7 days. And that's where they make that cultured epithelial sheets that can be placed on. So very handy for our burn victims and things like that. So if a larger graft is required, the cells can then be separated again and placed into a new medium. So you can just keep taking cells from the cultured epithelial sheets and then putting it into the new medium, which basically means that within 3 to 4 weeks, enough epidermis can be grown to cover an entire adult skin. And all this just from a 2 centimeter biopsy. Different ways to classify skin grafts can be the use of what's known as an isograft, which is very, very rare. You won't find it in many textbooks, because that's where you get a skin donor from an identical twin. Now, what can happen is also an allograft, which is where you get a sample from a human that's not you, and then you can even get a xenograft, which is coming from another species. For example, monkeys to man. Now, the reason we're speaking about skin grafts when we're dealing with modes of healing is skin grafts are commonly used in order to take advantage of trying to obtain primary healing or primary intention as best we can anyway, and often try to take advantage of at least delayed primary healing as well to minimize scar tissue and the probability of aberrants occurring. Now, what are aberrants? I may hear some of you say. Well, aberrants is just a term that when you're dealing biologically, it means a diversion or a diverging from the normal type. And what we're talking about here is we're talking about normal tissue type. So looking into it a little bit closer, tissue types can be defined in 3 categories. And if anyone's done any cellular study before, they're the same categories that are used for cells. So cells or tissues are essentially the same types of regeneration. So we have labile cells or labile tissues, and these tissues are ones that are continuously replicating. Okay, so they're what's known as mitotic cells. So they're constantly going through replacement. And these are found in your skin, your mucosa, and especially in your gut as well. Now, from labile tissue, you move into stable tissue. Now, stable tissue has the ability to regenerate, but it doesn't do it anywhere near as frequently as the labile cells, the labile tissue. And the last tissue type is your permanent tissue. Now, these ones are post-mitotic cells or post-mitotic tissues. So these are unable to replicate any form of normal growth. So once your normal growth is completed, then after that, you cannot replicate these cells. So that's your nerve cells, cardiac cells, skeletal cells, muscle cells, that sort of thing. Now that means that if a wound occurs in any of these areas that are permanent and not labile or stable tissue, then you're going to have to rely heavily on the impregnation of fibrous base and collagen fibers in order to fill the gap, and that's what leads to scarring, and that's what leads to the increased probability of aberrants. Now, I just spent some time going through some common aberrant type wounds, if you will. So the first one is what's known as exuberant granulation. Okay, so this is commonly called hypergranulation or overgranulation, and if anyone has horses, it's also called your proud flesh as well. Now, what happens is it's the accumulation of granulation tissue that protrudes beyond the wound surface. So this hypergranulation tissue can interfere with epithelialization. It may be soft and pliable and is often seen in the surgical incision lines or around drainage tubes and devices. Now, unfortunately, this hypergranulation can also occur around malignancies, and if that's suspected, a biopsy needs to be taken. But generally speaking, hypergranulation tissue only needs to be removed if epithelialization is retarded and the healing is impaired in some way. Now, the problem with epithelialization being slowed down in any way is it increases the probability of complications like infections, the accumulation of debris or dried exudate around the wound edges itself. It also increases the probability of having rolled or undermined wound edges, which means necrotic material can also form around the margins. But it's not all doom and gloom. There are things that we can do for exuberant granulation or hypergranulation. Now, the alteration of the wound's environments with dressings may actually control the hypergranulation and facilitate epithelialization. Now, things like angiogenesis, which is the formation of new vessels, is very important in the process of granulation tissue forming. Now, angiogenesis is promoted when the PO2 of a wound is lower, such as the case if you're having highly occlusive dressings. Despite this fact, they have found that having a less occlusive dressing is thought to facilitate epithelialization. So hypergranulation can be contained or removed by the presence of topical antimicrobials or antibacterial imbalances, using hypertonic saline impregnated dressings to control oedema and bacteria. Using local pressure apparatuses and foam dressings can also do it as well. And in a pinch, you can also use sharps and do wound debridement or chemical debridement as well. Okay, we'll move away from hypergranulation and we'll look at a term called hypertrophic scarring. Now, this is quite common and it's characterized by an overabundant deposit of collagen in the healed skin itself, and the presence of re-epitheliated red rames and firm scars that are often itchy. Now, the term hypertrophic scars is denoted because they're contained within the original boundaries of an existing wound. Now, they're often confused with keloid scars, which protrude beyond the boundaries, and we'll look at later on. It's thought that hypertrophic scars occur because of an imbalance between collagen synthesis and collagen lysis, so production and destruction. Hypertrophic scars themselves, they're commonly found following burns and generally around the neck area as well. Hypertrophic scars respond very well to pressure management, and to the extent that that's actually considered standard practice. So pressure management in the form of compression bandages or pressure garments has been used since like the early 1970s or so. Now, despite this being a common practice, they don't actually know how using pressure management works with hypertrophic scars, but the theories include that it helps the remodeling of the collagen bundles, it decreases the blood flow, which increases collagen activity, it decreases edema, and it can create a pseudo-hypoxic environment which may lead to fibroblast degradation and the decreased amount of collagen fibers being produced. Now, keloid scars, surprisingly, are more well known than hypertrophic scarring, even though keloid formation is much rarer. Now, keloids are, as well, fibrous growth as a result of abnormal connective tissue response to trauma itself. Now, like our hypertrophic scarring, keloids are characterized by the overabundance deposits of the collagen. The difference is, as mentioned, it goes beyond the skin wound boundaries and often deposits in this large, grotesque, tumorous looking scar itself. Keloid often occurs in darker pigmentation people, and there's often a familiar history or family history of keloid. They commonly occur around the head and the neck as well. Now, the big problem with keloid scarring as opposed to hypertrophic scarring is they do not regress spontaneously, and they may only repair if they're removed surgically. So pressure treatments don't often work. So treatments for keloid is varied and very challenging. So it often includes the surgical excision of the lesion itself by traditional knife or lasers. You can use compression garments usually afterwards. Other things like oral medications to interfere with collagen synthesis and radiotherapy has been used in the past. Now, the last one we'll look at is your contractures. Now, wound contraction is a very important and normal process of wound healing that we talked about in the previous lesson. So that's where the scar contraction pulls in on itself. Now, when the scar contraction is aberrant to the hearing, it can occur in the epithelialized wounds, resulting in cosmetic and functional disformity. So it's happening in the higher levels as opposed to the lower dermal levels where it's supposed to occur. Now, wound contractions appear to occur spontaneously with the formation of new granulating tissue. Now, the contraction pulls the wound edges together, resulting in the size of the wound surface and the amount of scar tissue required to fill the deficit to increase. Now, though the process of wound contraction is not fully understood, so why it happens in the epithelial as opposed to the dermal areas, it's thought to occur as a result of your microfibroblast activities. So the degree of this contraction is influenced by things like flexibility and mobility of the surrounding tissue itself. Now, contractions is facilitated in wounds upon loosening subcutaneous tissue, such as the abdominal region. In particular, scar contractures, on the other hand, they can occur in any anatomical location. So it doesn't have to be in a bony structure or the subcutaneous area of the abdominal. It can happen anywhere following an injury itself. Now, this pathological scar contracture that results in the cosmetic or functional deformity, it can be prevented according to some studies. Now, generally, the interventions to prevent it include things like splinting, frequent and gentle exercise around the wound, full thickness skin grafts if you're ever going to use it, and the wearing of pressure garments itself. Okay, that brings us to the end of this lesson. hope it gave a little bit more building blocks in your wound care toolbox itself. So then when we move on to other things, you can draw back on these lessons and it will make more sense. So the next lesson we're going to move on to is looking at how to do a general assessment of the skin itself. But until next time, take care.